Welcome to This Explainer. Today, we're jumping right in to unpack a real clinical case to understand exactly how fast diabetic ketoacidosis can escalate in a high-risk toddler. If you've ever wondered how a seemingly standard everyday childhood illness can just suddenly turn into a critical intensive care emergency in a matter of hours, well, you're in the right place. So let's start with a crucial question. Why is a common infection so dangerous for a toddler with type 1 diabetes? Look, for most kids, catching a fever is just a routine part of growing up, right? But for a child with type 1, the physiological math changes entirely. Their body's delicate metabolic balance is incredibly fragile, and a standard immune response can absolutely shatter it, turning a simple bug into a cascade of life-threatening events. To see exactly how this plays out in the real world, we're analyzing an academic clinical case presentation straight from the medical faculty in Skopje, mentored by Professor Dr. Marina Kristeva-Konstantinova. By walking step by step through this documented clinical practice case, we're going to trace the exact physiological breakdown and, crucially, the rigorous treatment protocols it took to save this patient's life. Section 1. A sudden medical crisis. Okay, every medical case has to start with the patient's baseline, and honestly, the baseline here is already deeply concerning. We are looking at a little boy who is only 2 years and 4 months old, and despite being so young, his short life already includes a known type 1 diabetes diagnosis and 3 prior hospitalizations specifically for severely disrupted blood sugar control. Now, he doesn't have any other significant underlying diseases, but those 3 previous admissions, they tell us right away that managing his glycemia has been just incredibly difficult. Section 2. Investigating the symptoms. So he arrives at the hospital, and the medical team immediately dives into investigating his distress. He was brought in with a sudden spiking fever hitting 39 degrees Celsius, which is about 102.2 degrees Fahrenheit. And that had just started the day before. But the thing that instantly raised massive red flags for the team was the severe vomiting. We're talking 5 to 6 times a day. For a tiny toddler, that rate of fluid loss points straight to rapid, extremely dangerous dehydration. The initial physical exam paints a picture of a body under immense stress. He was conscious, thankfully, but febrile and tachycardic, meaning his heart was just racing to compensate for the physiological strain. The doctors noted mild dehydration, but honestly, more alarmingly, listening to his chest revealed moist crackles in his lungs and a systolic murmur in his heart. Basically, his tiny body was sounding the alarm. Section 3. Confirming the diagnosis. Now, to comprehend the true danger he was in, we've got to look closely at his blood work. There is a clear, undeniable metabolic acidosis happening here. Normal human blood pH is super tightly regulated right around 7.4, but his blood pH had plummeted to a highly acidic 7.26, with bicarbonate depleted down to just 14 millimoles per liter. Paired up with that was hyponatremia, dangerously low sodium at 128 millimoles per liter, and an initially elevated CRP, which confirmed an active infection was driving all of this chaos. And it gets worse. Right alongside the acidic blood, further tests revealed severe hyperglycemia. His blood sugar was soaring at 17.86 millimoles per liter, and because his body couldn't actually use that sugar for energy without the proper insulin, it resorted to burning fat at a wildly dangerous rate. That resulted in a massive spill of toxic ketones into his urine, marked aggressively on his chart as 3 pluses. So what does this all mean? Well, this specific and deadly combination of high blood sugar, massive ketones in the urine, and highly acidic blood unequivocally confirms the diagnosis. It's the classic diagnostic triad for diabetic ketoacidosis, or DKA. It's an acute, absolutely life-threatening complication that demands immediate, incredibly precise intervention. Now, if you look at the standard DKA severity scale and compare our patient's labs, specifically that pH of 7.26 and bicarb of 14, we technically classify his DKA as mild. But let's be absolutely clear about this. In a 2-year-old child whose baseline health is already fragile, the clinical label mild still translates to an absolute no-questions-asked intensive care emergency. Section 4. The DKA treatment protocol. Recognizing the DKA is really only the beginning. Reversing it requires mathematically precise intervention. You can't just fix this with a single quick injection. The clinical team immediately locked into a standardized, super strict DKA protocol broken down into 3 critical, overlapping phases. Gradually replacing the lost fluids, carefully administering continuous intravenous insulin, and meticulously balancing his shifting electrolytes, primarily potassium.
Step 1 is the rehydration phase. They've got to replace that massive fluid loss carefully over a 24-hour period. They kick this off with a normal saline solution to stabilize his volume. But here is where the protocol demands strict attention. The second his blood sugar drops below 14 millimoles per liter, doctors must immediately switch that IV to a dextrose mix. Why? Because if you drop blood sugar too fast while rehydrating, it can cause a fatal shift of water straight into the brain cells, leading to cerebral edema. It's a delicate balancing act.
Next up is the insulin phase, reversing the underlying condition with a continuous insulin drip. They start at a highly calculated 0.1 units per kilogram per hour. And the medical team isn't just looking for a random drop in blood sugar. They are constantly adjusting the dose to hit an exact target drop of 3 to 5 millimoles per hour. If they go too slow, the acid continues to ravage his body, but if they go too fast, that brain swelling risk absolutely skyrockets. Then comes the hidden danger, which is potassium management. As the insulin finally allows sugar to actually enter the toddler's cells, it drags potassium right out of the bloodstream and into the cells along with it. This can cause blood potassium levels to just crash, which leads to lethal heart arrhythmias. Because of this, doctors have to vigilantly monitor serum levels and proactively inject potassium chloride into the IV the very moment it dips below 5 millimoles per liter. To safely pull off managing these rapidly shifting fluids, sugars, and electrolytes, the toddler obviously required a highly intensive monitoring protocol. We're literally talking about the medical team checking his vitals and blood sugar every single hour around the clock. Plus, they were drawing blood for electrolyte and gas analysis every 2 to 4 hours. It is an exhausting round-the-clock effort, but entirely necessary. Section 5, Clinical Recovery. So let's observe the results of this intense effort. Simply put, the protocol worked, his blood sugar normalized, and those toxic urine ketones finally cleared out of his system, leading to a huge overall clinical improvement. Interestingly, the case notes do mention he required thoracocutaneous drainage, a stark reminder of those complex respiratory issues hinted at by his early lung crackles. But ultimately, he was stabilized and successfully transitioned back to a daily maintenance dose of Fiasp and Tresiba insulin. Section 6, Key Medical Takeaways. The child survived, which is amazing, but what are the core lessons we should take away from this? The clinical report emphasizes that DKA remains one of the most common acute complications in children with type 1 diabetes, and standard infections, like the one that caused this boy's fever, are extremely frequent triggers. This case proves beyond a doubt that success totally relies on early symptom recognition, incredibly fast lab diagnostics, and an unwavering, non-negotiable adherence to standardized medical protocols. But the absolute most vital takeaway explicitly noted in the source material is this: very young children are an incredibly vulnerable risk group. Why? Simply because their little bodies have much smaller reserves. This allows a condition like DKA to progress from a simple fever to an acidic, life-threatening crisis at a terrifying speed. For them, time is a luxury they just do not have. Which leaves us with a really provocative final thought. Knowing exactly how fast this progresses in a 2-year-old with a history of poor control, could better, more proactive early warning protocols, like rigorous at-home ketone monitoring the moment a fever spikes, have intercepted this crisis before the toddler ever even reached the hospital doors? It's a critical question for the future of pediatric diabetes management. Thank you for joining me for this explainer, and I hope this deep dive really illuminated the incredible precision required in acute pediatric care.